Good morning, ladies and gentlemen, my dear friends. I'm Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, so Dr. Y. And today we'll talk about hospital-acquired pneumonia. So what's hospital-acquired pneumonia is? Hospital-acquired pneumonia develops at least 48 hours after hospital admission. The most common pathogens are gram-negative bacilli, gram-negative bacilli and Staphylococcus aureus. Antibiotic-resistant organisms are an important concern. Yeah, of course. Very important concern. Symptoms and signs include malaise, fever, chills, rigor, cough, dyspnea, and chest pain. Of course, chest pain. Diagnosis is not the cough. Cough is the most important anyway. Yeah? Cough is a classic sign of pneumonia. So diagnosis is expected on the basis of clinical presentation and chest X-ray, and is confirmed by blood culture on bronchoscopic sampling of the lower respiratory tract. Treatment, of course, is with antibiotics. Overall prognosis is poor due in part to comorbidities. Hospital-acquired pneumonia includes pneumonia that was not incubating at the time of hospital admission, so-called, and develops at least 48 hours after hospital admission in patients who are not receiving mechanical ventilation. Hospital-acquired pneumonia includes postoperative pneumonia, but doesn't include patients with ventilator-associated pneumonia. Okay? So about etiology. Etiology of hospital-acquired pneumonia. The most common cause of hospital-acquired pneumonia is microaspiration of bacteria. Yes, aspiration of bacteria that colonize the oropharynx and upper airways in seriously ill patients. Seeding of the lung due to bacteria of inhalation of contaminated aerosols. That is, airborne particles containing Legionella species, Aspergillus species, or influenza virus are less common causes. About risk factors. Risk factors for hospital-acquired pneumonia include previous antibiotic treatment, high gastric pH due to stress ulcer prophylaxis or therapy with H2 blockers or proton pump inhibitors, and coexisting cardiac, pulmonary, hepatic, or renal insufficiency. Major risk factors for post-operative pneumonia are age more than 70, abdominal or thoracic surgery, functional debilitation. Pathogens and antibiotic resistance patterns vary significantly among institutions and can vary with institutions over short periods, for example, months to months. Local antibiograms at the institutional level that are updated on a regular basis are essential in determination of appropriate empiric antibiotic therapy. In general, the most important pathogens are anti-gram-negative bacilli, especially Pseudomonas aeruginosa, gram-positive cocci, gram-positive cocci, especially methicillin-sensitive Staphylococcus aureus, and methicillin-resistant Staphylococcus aureus, MRSA. Other important anti-gram-negative bacteria include Enterobacter species, Klebsiella pneumonia, Escherichia coli, Snernatia marsensis, Proteus species, and Acinetobacter species. Methicillin-sensitive Staphylococcus aureus, Streptococcus pneumonia, and Haemophilus influenza are most commonly implicated with pneumonia develops within 4 to 7 days of hospitalization, whereas Pseudomonas aeruginosa, Mercier, and entering gram-negative organisms become more common with increasing duration of hospitalization. Risk factors for infection with multidrug-resistant MDR. Multidrug-resistant pathogens include prior intravenous antibiotic treatment within the previous 90 days, structural lung disease, colonization with MDR pathogens, and high rates of prevalence of these pathogens in the local hospital environment. Infection with a resistant organism markedly worsens mortality and morbidity. High-dose corticosteroids increase the risk of Legionella and Pseudomonas infections. High-dose corticosteroids. Chronic suppurative lung disease, such as cystic fibrosis and bronchiectasis, increase the risk of gram-negative pathogens, including antibiotic-resistant strains. There is an increased recognition of viruses as cause of HAP, so hospital-acquired pneumonia, in immunocompetent patients, and of viruses and fungi in immunocompromised patients. So there is, once again, please, there is an increased recognition of viruses as a cause of hospital-acquired pneumonia in immunocompetent patients, and the viruses and fungi in immunocompromised patients. Fungi. So symptoms. Fungi. Not fungi, but fungi. Okay. Symptoms and signs of hospital-acquired pneumonia. Symptoms and signs of hospital-acquired pneumonia in non-intubated patients are generally the same as those of community-acquired pneumonia and include malaise, fever, chills, rigor, cough, dyspnea, and chest pain. Actually, I will now show you a link. You be careful. Go with this link to find this community-acquired pneumonia. Okay? All you can find there. Absolutely. So, diagnosis of hospital-acquired pneumonia, chest X-ray or chest computed tomography, and clinical criteria: limited accuracy. Sometimes bronchoscopy or blood cultures. Usually, a diagnosis is made based upon a new lung infiltrate combined with clinical features of infection, which include the new onset of fever, purulent sputum, leukocytosis, and decline in oxygenation. However, clinical diagnosis is imperfect. No symptom, sign, or X-ray finding is sensitive or specific for the diagnosis of hospital-acquired pneumonia, because all can be caused by atelectasis. Pulmonary embolism and pulmonary edema. Gram strain and semi-quantitative cultures of sputum samples, though not definitive for identifying infection, should be done because they can direct empiric therapy. Bronchoscopic sampling of lower airway secretions for quantitative culture yields more reliable specimens that can differentiate colonization from infection. Information gained from bronchoscopic sampling reduces antibiotic use and assists in switching from broader to narrower antibiotic coverage. However, it hasn't been shown to improve outcomes. Measurements of inflammatory mediators in bronchoalveolar lavage, fluid, or serum hasn't been shown to be reliable in deciding of initiation of antibiotics. The only finding that reliably identifies both pneumonia and responsible organism is a pleural fluid culture obtained by thoracocentesis in a patient with pleural effusion that is positive for a respiratory pathogen. Blood cultures are relatively specific if a respiratory pathogen is identified but are insensitive. Molecular tests that identify the pathogen and resistant patterns in respiratory secretions are emerging and could be useful in guiding treatment. Now about prognosis and treatment. The mortality associated with hospital-acquired pneumonia is higher despite the availability of effective antibiotics. However, not all mortality is attributable to the pneumonia itself. Many of the deaths are related to the patient's other underlying illness. Adequacy of initial antimicrobial therapy clearly improves prognosis. Yes. Of course, adequacy of initial antimicrobial therapy clearly improves prognosis. Infection with antibiotic-resistant, gram-negative or gram-positive bacteria worsens prognosis. So it was about prognosis. At treatment. Empirically chosen treatment of hospital-acquired pneumonia. Empirically chosen antibiotics active against resistant organisms. If hospital-acquired pneumonia is suspected, treatment is with antibiotics that are chosen empirically based on local sensitive patterns, patients' risk factors for antibiotic-resistant pathogens. In the 2007 guidelines, the Infectious Disease Society of America and American Thoracic Society used very broad criteria for defining the population at risk of infection with antibiotic-resistant pathogens, which resulted in the majority of patients with hospital-acquired pneumonia required broad-spectrum antibiotic therapy for MRSA and resistant Pseudomonas. The current 2015-2016 recommendations emphasize use of a narrower spectrum of empiric antibiotics when possible. Empiric therapy for hospital-acquired pneumonia without increased risk for antibiotic-resistant bacteria due to prior intravenous antibiotic use within 90 days in an institution where MRSA incidence is less than 20%, of Streptococcus aureus isolates and Pseudomonas aeruginosus resistance is less than 10% for commonly used empiric anti-pseudomonal antibiotics could include any of the following: piperacillin, tazobactam, cefepime, levofloxacin, impianem, meropenem. Dose dependent of renal function. Doses depend on renal function, of course. In treatment settings where MRSA rates are more than 20%, vancomycin or linezolid should be added in patients who have risk factors for antibiotic-resistant organisms or in the absence of reliable local antibiograms. Recommendations include triple therapy using 2 drugs with active against Pseudomonas and 1 drug with activity against MRSA. An anti-pseudomonal cephalosporin, cefepime or ceftazidime, or an anti-pseudomonal carbapenem, impinem, meropenem, or a beta-lactaminase inhibitor, piperacillin, tazobactam. An anti-pseudomonal fluoroquinolone, ciprofloxacin or levofloxacin, or aminoglycoside, amikacin, gentamicin, tobromycin, linezolid or vancomycin. While indiscriminate use of antibiotics is a major contribution to development antimicrobial resistance, adequacy of initial empiric antibiotics is a major determinant of a favorable outcome. Therefore, treatment must begin with initial use of broad-spectrum drugs, which are then changed to the narrowest regimen, possibly based on a clinical response and the results of cultures and anti-antibiotic susceptible testing. So, key points. Hospital-acquired pneumonia is a pneumonia that develops at least 48 hours after hospital admission in patients, most receiving mechanical ventilation. Likely pathogens differ from those causing community-acquired pneumonia and may require initial empiric antibiotic therapy that is positive against antibiotic-resistant organisms. Diagnosis is difficult, which culture of a potential pathogen from pleural, fluid, or blood being the most specific finding. Rhesus patients at 2 to 3 days after reassess patients 2 to 3 days after initiation of treatment and change antibiotics based on available culture and clinical data. So I suppose it's largely enough about this hospital-acquired pneumonia. Huh? That's enough, yeah. So, ladies and gentlemen, my dear friends, thanks a lot for your attention. Don't forget to make your donations. Don't forget to do this, because based on your donations, we exist. It will be highly appreciated. So don't forget to follow and subscribe our channel, Dr. Y. Bye. See you in next lectures. God bless you.